Welcome to the regular meeting of the Public Health and Safety Committee for March 27, 2024. I am Jason Chavez, and I am the chair of this committee. I want to note for the public record that Vice Chair Wansley reached out ahead of time and that she will not be present in committee today. At this time, I will ask the clerk to call the roll so we can verify the presence of a quorum.
Councilmember Payne.
Present.
Rainville.
Present.
Ellison.
Here.
Palmisano is absent. Vice Chair Wansley is absent. Chair Chavez.
Present.
There are 4 members present.
Let the record reflect that we have a quorum. With that, the agenda for today's meeting is before us. There are 3 items on today's consent agenda. Item number 1 is authorizing the submittal of a grant application to Hennepin County's Healthy Tree Canopy Grants for exploration of developing a tree preservation ordinance. Item number 2 is authorizing the submittal of a joint grant application with St. Paul Ramsey Public Health to the Minnesota Department of Health for the Transforming the Public Health System Innovation Projects Infrastructure Fund to analyze the feasibility of safe recovery sites. And item number 3 is approving a legislative directive to create a work group to develop environmental justice goals that would reduce air pollution and other off-site impacts. Are there any discussions on these items? And I will note for the public record that Councilmember Palmisano has joined us. Seeing none, I'll move approval of the consent agenda. All those in favor say aye. Councilmember Rainville.
When I vote, I'm going to vote no on number 2. So I just want to make that clear ahead of time. But please call the vote.
I could split up the vote too. So what I'll do is I'll move approval of item number 1 and item number 3. And I'll just pull out item number 2 for a separate vote, just to make things more clean. So, all those in favor, the clerk, if you can help us with that.
Okay, so calling the roll on items 1 and 3?
Yeah.
Okay. Councilmember Payne.
Aye.
Rainville.
Aye.
Ellison.
Aye.
Palmisano.
Aye.
Chair Chavez.
Aye.
There are 5 ayes on item 1 and 3. And now item number 2.
Yep, the motion failed.
Councilmember Payne.
Aye.
Rainville.
No.
Ellison.
Aye.
Palmisano.
Aye.
Chair Chavez.
Aye.
There are 4 ayes and 1 nay.
And that is approved. And that those items carry and the consent agenda is approved. The next item is receiving and filing a presentation on the state of Minnesota's response to the opioid epidemic. Here to present on this item is State Director of Addiction and Recovery, Jeremy Drucker. One of the goals of this committee is to foster partnerships with government agencies and community groups to address ongoing and emerging health and safety challenges. I want to thank Jeremy for joining us today. If you can just come up here, and we'll be ready to go. And welcome.
Great. Thank you, Mr. Chair and committee members. Really appreciate the opportunity to come and share a little bit about what the state is doing to respond to the opioid epidemic. And I really appreciate your comments about partnership. We had a chance to speak a little earlier. That's sort of the essence of the state's role in human services. We have what's called a state-sponsored, county-administered human services system, which means most of the work is done at the county and local level. And so really, partnerships are a key to how we get our work done to serve the people of Minnesota. So I really appreciate the spirit of that and certainly reciprocate that as well. My name is, as the committee chair said, my name is Jeremy Drucker. I am the State Director of Addiction and Recovery. In this role, I chair a sub-cabinet that includes 8 state agencies, including the Departments of Health, Human Services, Corrections, Public Safety, Education, Higher Education, the Interagency Council on Homelessness, and Minnesota Management and Budget, where my office is currently housed. Just wanted to set the stage real quick on just sort of the status of the opioid epidemic in Minnesota and just get a sense of where things stand right now. I think one thing I like to point out too is we're talking about the opioid epidemic. Certainly, it's an epidemic, and we need to marshal our resources to combat that. But I think it's just important also just to remember that opioids are not the only substance that are harming Minnesotans. Just keeping in mind that alcohol and there are other drugs like methamphetamine, cocaine are also taking tolls on our communities. And so, just like to set that stage and just remind folks that, for instance, excessive drinking alone costs Minnesotans about $8 billion a year in costs associated through loss of productivity, healthcare, and other issues. And so just want to foreground that. And then also just to foreground just sort of the number of people in treatment in Minnesota. In 2022, there were about 63,000 people who were admitted to substance use disorder treatment programs. 14,600 of them, so almost 15,000, were in Hennepin County alone. So just to kind of give you a sense of the scope. I would also say that individuals who access treatment, it's probably only about a quarter of individuals who need treatment access treatment. So really looking at that figure, many more Minnesotans than that actually need help who are not getting it. When it comes to the opioid epidemic, nationally in 2022, 6.1 million Americans 12 or older had an opioid use disorder. There were over 100,000 deaths related to opioids. In Minnesota, overdose deaths increased by 43% from 2020 to 2022. In Hennepin County, there were 377 people died of an opioid-related overdose in 2022. In Hennepin, 2,600 people were admitted to treatment for opioid use disorder, and that is just a fraction of the number of people who need help. So clearly, this is an epidemic. Clearly, it is a growing problem. If you look at the chart, you'll see that overdoses did begin to level off somewhat in Minnesota in 2022. I think no one is taking that for granted. I think we're watching that number very carefully. The numbers that Minnesota is seeing also represent national trends as well. So the entire nation is seeing a similar trend right now. Substance use disorder, and opioids, while it impacts every community in Minnesota, it does hit different communities differently and with a different impact. This council is well aware of the disparities that Minnesota has. Those disparities are also reflected in overdose deaths, and so the state is really focused on how we can mitigate those. But just to flag some of the main population ones that stand out to us here at the state. When you look at overdoses since 2015, 1 in 5 overdoses occurred from an individual who was released from a correctional facility within the last year. Of those, 20% were within 2 weeks. So that's a population that's highly susceptible to overdose, and there's a high connection between substance use disorder and recidivism as well. And so tackling one addresses the other, and we'll say a little bit more about that later in this presentation on some initiatives the state has going on there. Also, 1 out of 10 overdoses were from an individual that was experiencing homelessness. 1 in 3 deaths among homeless Minnesotans was attributed to an opioid overdose, and so that's another population that we're really focusing on how we can provide care and better support for that population. Additionally, when you look at overdose deaths, if you're Native American, you're more than 9 times more likely to die of an overdose death than if you're a white Minnesotan. If you are Black, over 3 times as likely to die of an overdose. And so, again, those same disparities that we see in other elements of society are also replicated here in overdose deaths. Some of the key takeaways that are not just in Minnesota, but nationally, I think that we've seen from the opioid epidemic is that, of all the overdoses in Minnesota in 2022, 75% of those overdoses were involved at least one opioid. Fentanyl is involved in almost all of those opioid-involved overdose deaths. I think fentanyl really, the phrase has tipped the market in 2018 here in Minnesota, and that's when we really saw a skyrocketing in the overdose deaths. Fentanyl is 50 times more powerful than heroin, and so given the potency, given how quickly people become addicted, and given how significant withdrawals are and how difficult it is to help people through those and find treatment and find recovery, it's really changed the way that both locally and nationally strategies that we've employed to really address this epidemic. I would also add, though, too, that the drug landscape is changing and it's dynamic. What it looks like today today is different than what's going to look like tomorrow. It's different than what it looked like 16 or 10 years ago. You know, I think originally what we saw with the opioid epidemic was it was precipitated by some of the excesses we saw with Big Pharma around Oxycontin, oxycodone, prescription drug medicines. Heroin then replaced that as more protections were put in place with prescription drugs, and then fentanyl has now replaced heroin as one of the primary drivers. There are also other adulterants increasingly becoming apparent in the illicit drug supply. Xylazine being a big one. It almost always comes along with fentanyl, but that is a big concern here. We have not seen the same rate of xylazine involvement as, say, out on the East Coast, but it's something we're watching very carefully here because there are really significant health impacts that come with xylazine. And for those unfamiliar, xylazine is an animal tranquilizer. It prolongs the duration of fentanyl, so it often is mixed with it. It can cause really significant and substantial sores, can lead to amputation. Really, there's a lot of disease that can come with it too. So it's something of grave concern. But there are strategies that work, and so despite how prevalent fentanyl is in the opioid epidemic, there are strategies that work that both locally and nationally we've seen that can help respond to this. One is medications for opioid use disorder. So there are three main medications for opioid use disorder: methadone, buprenorphine, and naltrexone. There are really good outcomes when individuals have access to those medicines for opioid use disorder. They are still relatively new, and so there's still a lot of stigma attached to those, and so really helping make sure that all communities have access to those medicines for opioid use disorder is key. And then also harm reduction. I'm going to show a slide here in a minute, but harm reduction is a approach. It is like many things, there is a continuum of harm reduction services, everything from naloxone on one end and Narcan all the way to safe recovery sites or safer consumption sites, and there's a lot of room in between too. So there's not just one modality of harm reduction, and so, but as a philosophy, as a way of approaching drug use, it's a way to keep people alive, and given the potency of fentanyl, given how quickly people can overdose, it's really probably our best tool in the toolkit right now to help people survive long enough to find a recovery journey. For the state's response, one of the things that I mentioned this earlier, sort of this notion of partnerships, and I mentioned sort of the way that the human services system is constructed in Minnesota. You know, at the state, we are really focused on strategic alignment, so making sure that the state is working in concert with our legislative partners, with tribal, county, and local level efforts. So what's happening in Hennepin County, what's happening with the city of Minneapolis, what's happening with the Opioid Epidemic Response Advisory Council. So that's the advisory council that spends the state share of opioid settlement funds. And then also, what are our federal partners doing? What is SAMHSA? What is the CDC? What are the grant opportunities that they're providing, and some of the Medicaid opportunities that they're providing as well? One of the ways that the state addresses big topics, whether it's childcare, whether it's climate change, or in this case, overdoses, is to incorporate it into what's called the One Minnesota Plan. This is the state's strategic plan. And so opioid overdoses and reducing the impact of the opioid crisis on Minnesotans has been absorbed into the state's strategic plan. Those are really focused strategies that do not encompass the totality of the work around opioids, but are two areas that we're really focusing on. One is around justice-involved individuals, and so these are individuals, and I showed that stat earlier about 1 in 5 Minnesotans who experiencing overdose had a justice-involved background. So really focusing on justice-involved individuals, and we define that as individuals who are encountering law enforcement on the front end, currently incarcerated, exiting incarceration, or have a justice-involved background. And then the other area that we're really focusing on is adolescent substance misuse. And so this is really focused in that area of prevention, of getting ahead of an issue before it gets getting upstream. The focus metric there you'll see is still under development. That work is still is really just getting off the ground, but that's going to be a key area that we focus on. Sort of the way that we organize sort of the One Minnesota Goal piece, we have action teams that convene around these things, and so the Office of Addiction and Recovery is sort of leading these efforts. In the justice involved and adolescent space, you can see that. You'll also see a third action team there, unsheltered individuals. That's another key priority for us, is how we can attend to the substance use needs of Minnesotans experiencing homelessness. That work is in the housing stability goal area, and we really do that work in partnership with the Minnesota Interagency Council on Homelessness, and I'm happy to speak more about that later if you'd like. But how we address this at the state level and how we look at it is we look at an entire substance use disorder continuum of care. So everything from prevention, harm reduction, treatment, and recovery. I like using this slide partially because of what's not on here. You'll note that the slide is from 2016, and just to make that point of how changing modalities and changing strategies with the changing of the crisis, harm reduction is not mentioned on here as part of the continuum. It's now nationally recognized as part of that continuum, and that's a big part of the state's effort to address to combat opioids. But you'll see here from that whole kind of continuum, we really focus on strategies that touch each and every part of that continuum. Just a quick primer too on, because at the state level, as I said, we are a state-sponsored or state-supervised, county-administered system, so we operate from a funding perspective primarily. There are four main categories of funding for how we fund substance use response. Medicaid is the primary method. Medicaid is a joint federal program. I'm sure many of you are aware of it. The state spends, puts up a match and gets federal dollars. It's an entitlement program, which means if you're eligible for this program, you are covered under those services, and so there's no capped dollar amount. It's what we call at the state level a forecasted program. It is a very powerful tool and a powerful payer. It's also a very complicated one, and so the rules and regulations around Medicaid are often subject to a lot of discussion up at the legislature, but they can unlock significant resources to address the issue. I would say when we look at that continuum of care too, Medicaid primarily funds treatment. It does fund some recovery services as well, but it's the primary funder of treatment. And I would say that when you look at how we spend dollars at the state level, the vast majority of dollars go to treatment. So prevention, harm reduction, and recovery, those are primarily funded by grant dollars, not as powerful of a funding mechanism. And so in 2021, for instance, only about 5% of state spending went to prevention and recovery, less to harm reduction. The vast majority went to treatment. The 2023 legislative session, I'll share some information there in a moment, helped kind of allowed us to invest in other parts of the continuum, which we took advantage of. But again, I would also say too that the primary way that we pay providers through Medicaid is through rate structure, and there is a rate problem. The Department of Human Services did a study in 2023 that found our rates for substance use providers are too low, and that's a challenge that the state is going to have to take on and think about how to address that going forward. But so it's a complicated financing picture, but Medicaid is a significant part of that solution. We also have a program in Minnesota. It's a Minnesota-specific program. It is a really funky fund. It's called the Behavioral Health Fund. It's a mixture of a lot of different payment sources, but it primarily funds treatment for those who are Medicaid eligible but who are not currently enrolled in Medicaid. Then we have state and federal grants. These are capped, as you are all probably familiar with grants. They are capped dollar amounts. Once the money runs out, the program sort of ends unless it gets renewed. And again, that is the primary funding source for prevention, harm reduction, and recovery pieces of the continuum. And then finally, I would just mention the opioid settlement funds. The state of Minnesota is projected through the first and second wave settlements over 18 years to receive about $500 million. 25% of that goes to the state, 75% of that goes to counties and cities over 30,000. And so Minneapolis certainly has its own settlement funds, and I'm sure they can talk more about that later. So those are sort of the buckets of financing that we look at the state level as we're thinking about how to fund the things that we need to fund. In 2023, I think all of you know that we had a significant historic legislative session. There was a $17.6 billion budget surplus. allowed us to do a lot of really good things in a lot of areas. One thing that sometimes gets left out, which I think it's important to note, is that it was a $17.6 billion surplus, but only about $6 billion of that was ongoing money, which means that ongoing money is very difficult to spend in the human services space because oftentimes you're taking on obligations that you want to continue. You don't want to create cliffs. And so going back to that rates point I made earlier, rates are ongoing spending, and so it's the toolkit there was a little narrower than that $17.6 billion might appear at first blush. But we were still able to make a lot of significant investments in substance use disorder. So over $20 million over 4 years was signed into law last legislative session. Many of those proposals were really focused on reducing deaths in the communities where the disparities are greatest. So American Indian and Black communities. Many of those investments also cross that entire continuum of care that I shared. They also, many of them looked at the intersection of substance use with other systems such as corrections, housing, primary health care, and other supports. Overall, though, I would say that the 2023 budget session significantly moved Minnesota much further towards a public health approach to substance use disorder. So really what we want to do is addiction and substance use disorder is a healthcare condition. We don't want to criminalize addiction. Even our colleagues, all of our colleagues in the legislature, I was just at a public safety hearing yesterday, agree that that is not a good thing to do. That's just historically been the way that we have approached this issue. And so I think we made strides in the 2023 legislative session to decriminalize addiction while maintaining certain important safeguards around public safety. Some of the legislative highlights, and I'll say more about the safe recovery sites in a moment, but that was one of the things that we accomplished last session. We also were able to fund harm reduction for culturally specific organizations, more dollars for family treatment, startup and capacity building grants, treatment quality enhancements, peer support investments. You've got this document. I'm not going to walk through each one of these, but if there's any questions, please feel free to follow up, and I'm happy to give more information on those. I would just add, though, that these dollars are just beginning to go out the door now. Some of them have not started going out the door yet, but many of them are starting to go out, and so funding opportunities will be available for the city as those dollars start heading out. Some of the state efforts, specifically across the continuum, just to give you a sense of how we look at it too. When we look at prevention, anti-poverty measures like the children's tax credit is fundamentally prevention. We know that the same social determinants of health that affect health in other areas also affect substance use disorder. So all of the anti-poverty measures that were signed into law, I view as the technical term is primordial prevention, but really about improving the quality of life for people to reduce susceptibility to substance use disorder. But also there was dollars for public awareness campaigns to reduce stigma, promote treatment and well-being, community-based prevention support. So some RFPs went out from the Department of Health for community-based prevention programs, culturally specific outreach, making sure that there was an RFP that went out from the Department of Health, really focused on the American-born Black population, but also opening up some dollars for the East African community too for recent arrivals. And then looking at how we can disrupt pathways to adolescent substance misuse. So we know that adverse childhood experiences, or ACEs, elevate people's susceptibility to substance use. So any of we have multiple campaigns and initiatives underway to sort of lower those ACEs scores. Harm reduction was another thing we invested in significantly. So naloxone was a big one. Legislation was passed last session requiring that schools, jails, treatment centers, law enforcement, and some other congregate settings had naloxone. The state also created a centralized distribution portal for free naloxone for those mandated groups, and then has recently opened up that naloxone, that centralized distribution portal for tribes and for organizations serving Minnesotans experiencing homelessness. So really trying to get as much naloxone out into the community as possible. Safe recovery sites I'll say more about in a little bit. Syringe service programs are widely recognized to improve public health, improve public safety, and there's research that show the CDC has studied these for 30 years or more, has shown that individuals who interact with a syringe service program are 5 times more likely to enter treatment. And so these are a really good opportunity to meet people where they're at. And so did a lot of good work, I think, last session in developing some programs and some funding to support syringe service programs. The Department of Health is creating harm reduction, health, and housing hubs. It's an RFP that's gone out. I think it's closed at this point, but it's really focused on integrating some of these harm reduction principles with some of our homeless shelters and points where we can connect people who are experiencing substance use issues with housing and other supports. One of those will be in Greater Minnesota, one of those will be in the metro, and then one of those will be focused on the Native American population. And then some other items too that were passed that are still in development is an overdose surge alert text system, so that the Department of Human Services is working on that, so folks will get notified if we start seeing surges in overdoses in a particular community. Treatment, huge component of the substance use continuum. It's really the backbone of the substance use disorder continuum. So a lot of attention being paid there, especially in expanding access to medicines for opioid use disorder. Really looking at not just expanding access in sort of traditional settings like in withdrawal management or even primary care settings, but what are really some low threshold programs we can make to expand access to medicines for opioid use disorder for folks. I would just add that there's a lot of federal regulation around medicines for opioid use disorder, but this is a really dynamic space where the federal government is rapidly changing their some of their regulations, and so we're being agile at the state to make sure that we're taking advantage of those opportunities as they come along. And then traditional healing, I would say another big point of emphasis that we have is really culturally specific treatment and recovery support. So we had a American Indian SUD Summit in August up at Fond du Lac, and I participated in the Department of Human Services tribal consultations. What we have heard from our tribal partners is just the importance of traditional healing. There's also a lot of research that shows that for individuals of American Indian descent, traditional healing has outcomes as good, if not better, than conventional Western approaches. And there's a lot of opportunity, and I've seen it up at Red Lake in particular, sort of the blending of the two approaches that have shown some really good outcomes. So really looking at how we can support traditional healing practices is a big focus of the administration. And then finally, recovery. So one of the main ways we support recovery is through peer support, peer recovery support specialists. Funding was established last year for recovery community organizations, which are one of the primary trainers of peer support specialists, to offer more peer support for free. I would also add that peer recovery support is a Medicaid reimbursable service. Again, there are some rate issues there that have to be worked out, and it's what I would call an emerging profession, meaning there's still a lot that we have to learn in how to maximize that, but it's shown a lot of really good outcomes, especially in different systems such as corrections, homelessness, in the child protection system, and so that's an area that we're really focused on as well. The Safe Recovery sites, there's been a lot of attention paid to this. That was passed last session. Where the state is at with that is, we are really moving deliberately and carefully in this area. As we've had conversations with our partners, both with harm reduction partners, also with our partners in law enforcement, the message there we're really getting is that, let's do this well, let's not do this fast. And so the state is really moving deliberately. We're still moving down this path. Right now, state is doing a lot of research into what these might look like in different communities in Minnesota. I think the goal here was we wanted to offer communities a toolbox with which they could, with as many tools as possible, with which they could choose in how they wanted to address the opioid epidemic. And so there's a big community engagement component to this. we did announce back in December, I believe, that the first round of funding for the safe recovery sites would not include the safer use component. They would be capacity building grants, and so we continue to move down this path. But no RFPs have been released yet. We anticipate those initial RFPs coming out sometime this summer, and certainly we'll be in contact with local public health on that. The other one I wanted to, and then I would just add to that part of that legislation and really focusing on where where the community is most disproportionately impacted. The legislation specifically calls for priority to be given to safe recovery sites that would serve American Indian Minnesotans and Black Minnesotans. So again, just recognizing the disproportionate harm being done there. The other thing I wanted to flag, and this is a 2024 proposal in the governor's budget recommendation, and I mentioned earlier Medicaid and the role that Medicaid plays in providing services to individuals. There is a federal law called the Federal Inmate Exclusion, which means that if you are incarcerated, you are not eligible, your health care is not eligible to be paid for by Medicaid. The Biden-Harris administration has opened up an opportunity where states can waive that particular regulation and provide services up to 90 days pre-release. It's called a reentry waiver. The governor has a recommendation around that for phase 1 of that waiver. It's a pretty gigantic undertaking, but it really has, I think, the opportunity to be transformational in how we provide care to individuals who are currently incarcerated, and then how those individuals will have continuity of care as they re-enter back into society. So happy to talk more about that, but it's something that the Walz-Flanagan administration is really interested in, and I think it opens up a lot of, as I said, Medicaid is a very powerful payer, but it's also a very complicated payer. And so you'll see the services that are in the governor's proposal there are care coordination, prescription drug coverage, and a 30-day supply of prescriptions upon release, substance use disorder, comprehensive assessments, treatment, and coordination, including medicines for opioid use disorder, other behavioral health services, family planning, and physical health, well-being, and screenings and care for adults and youth. So with that, I will just stop and happy to take any questions, and really hope that this can be the beginning of a conversation. Certainly understand that there was a lot of information that was packed into a relatively short presentation, so thank you.
No, thank you so much. It was very informative, and like we mentioned earlier, it's helping us. More information, the better. So it helps us make better informed decisions. I'll pass it to Council President Payne. We also have the queue. Council President Payne doesn't have his queue, so that's why he's going to be using this tag.
Thank you, Chair Chavez, and thank you for being here. This is just really enlightening. It's building off some work we started last year, but we're going from understanding the problem to trying to solve it, and I feel like we're still kind of in that transition period right now where it feels like we on this body at least have a much deeper understanding, but we're still not quite where we want to be from a solutions perspective. One of the big things I've been thinking a lot about is just how do you fund that solution, even if we knew what that solution was, which we have some ideas about what's going to work. So my question is, from a funding perspective, we talked a lot about reimbursement and Medicaid. It seems to me that there's two different ways to break it down, like what's a reimbursable intervention, and then like, is it the appropriate amount of reimbursement? And I'm just curious, for both of those questions, the role of the state versus federal government, and then even within that, the role of the administrative branch versus legislative branch in either of those scenarios.
Thank you, Mr. Chair, Council President Payne. So I'm going to preface this because Medicaid is super complicated, and so I am not a Medicaid expert, and so I will go as far as I feel I can go without crossing any boundaries my colleagues might shiver at. I think to the question of what are the reimbursable services and then what are the rates, those are a combination of state and federal decisions, mostly state. And so there's an old joke that if you've seen one state's Medicaid plan, you've seen one state's Medicaid plan. They're all different. The state's Medicaid plan is called a state plan amendment. So the state works in conjunction with the federal government to create what is its services. So what is reimbursable, what's not reimbursable? That's a negotiation between the Departments of Human Services and CMS, generally at the federal level. Oftentimes, the state legislature and the administrative branch, because whenever you're talking about Medicaid and what's reimbursable and not, you're talking about there's going to be a funding implication. So that necessarily involves the legislature. And so those are generally conversations that are conversations that are had between the executive branch and the legislature and passed into law. So for example, the 1115 reentry waiver, this would open up the state's Medicaid benefit set for this certain population of individuals. We would need state authority to request that, and then we would also need state authority for the additional spending that would go into what it would cost the state. And generally speaking, the way that the costs are broken out, it's broken out by service. It's also broken out by population category. And so, for example, a very simplified version of this, and it's just an example, is generally speaking, Minnesota sort of maximizes its federal the Medicaid program. So it's essentially a 50-50 split between Minnesota and the federal government in most cases. Because of the Affordable Care Act, and one of the things the Affordable Care Act did was it did Medicaid expansion. Medicaid expansion was incredibly helpful and a powerful tool to expanding coverage. One of the things with that expansion population was individuals, childless adults primarily, under 138% of the poverty level could now be covered under Medicaid. That's a 90-10 federal match in most cases. And so the proportion changes depending. So just to give you an example, the services are legislative and then a negotiating piece with the federal government. Reimbursement rates are done primarily legislatively because it's it has an impact on the state budget. And then I need to confirm this, but I believe those rates are then done in consultation. There's also a CMS negotiation there, but don't hold me to that. So the rate conversation around that rate study that I mentioned, that's going to be a conversation with the executive branch and the legislature at some point.
That's really enlightening. And I mean, I definitely don't have expertise in Medicare and Medicaid. And I think even if I did, like you said, it would be limited to whatever context. But it does seem like there's like a general principle you could explore here around there's probably a tension between the number of services that you reimburse is going to mean the more money you have to raise to reimburse those services. So you're probably constantly balancing a lower reimbursement rate to facilitate more services. And it sounds like there's maybe a different matching mechanism depending, or a matching ratio depending on the specific service with the federal government.
So, Mr. Chair, Councilmember President Payne, I think there's always the conversation. To borrow a phrase from our hospital friends, there's a payer mix. And so generally speaking, the payer mix is commercial rates pay the highest rates, Medicare rates pay the second highest, and then Medicaid are generally the lowest paying rates. I would add that in the substance use disorder space, the vast majority of treatment is paid by Medicaid. And so this is a heavily financed by public programs. There's always and our provider community is an integral partner in this conversation because our providers need to have business models that are successful. And so I think part of that conversation is about what does the state have in its ability to spend, and so what are the priorities that the legislature and the governor as a whole are putting forward as we look at needed funding in education and public safety and other areas than what we want to spend in human services. And then it's also a question of what do our providers need in order to provide the services that we want them to provide? And so, I don't want to speak too much for our provider community, but I think the SUD provider community has been very clear that the rates are too low. The DHS study that was done has certainly, I think, validated that. I think the question is what can we do at the state, given we have a fixed budget? What can we do to address that going forward? And then there are questions too related to that in terms of quality of what can we expect from a quality perspective if our rates are at a certain level. And so I think there's a lot of factors that go into that conversation, but that's often what happens up at the legislature.
Okay, and then maybe my final question around housing. This came up in a conversation last PHS meeting where we hosted the county attorney, and there's discussion around youth diversion and kind of the intersectionality of some of the challenges that youth have and their housing stability, and how that is like an intersectionality that's making for worse outcomes. Housing is a huge intersectionality when it comes to substance use disorder. And one of the topics of discussion was around licensure for housing providers that are supposed to be, I think it's the 345D license, I can't remember the specific license, but for basically supportive housing services, and how there's a lot of challenges around that. Is any of your body of work entering into the realm of housing, especially as we're like getting into the complexity of funding? Medicaid is a very complex funding mechanism. HUD has some very complex funding mechanisms. Is there any intersectionality on how your body of work it like combines with the housing challenges?
Yes. Excuse me. Chair Chavez, Councilmember President Payne. Yes, I think those are definitely conversations that are happening. I think we work really closely. My office, the Office of Addiction and Recovery, works really closely with the Interagency Council on Homelessness, who works very closely with Minnesota Housing Finance, and so really looking at what are those. And we know that there's a continuum of housing, just like there's a continuum of substance use disorder. And so what are the right housing options for the right people? I would say one of the things that I'm very I'm very focused on is in the recovery space. We call it recovery capital, but how do people achieve and sustain momentum in their recovery? And so these are things like a job, education, housing. It's very hard to be in recovery if you don't have a house, if you don't have stable housing. It's very hard. It's just a fundamental component of life. And so there's a lot of conversations and a lot of collaboration between those two spaces. I would say my office and my work is kind of a supporting actor in that, but we certainly are connected. One of the things at the Department of Human Services, which is the Medicaid authority for the state of Minnesota, that also has a housing component to it as well. And so at the Department of Human Services, a lot of those conversations are constantly happening.
Thank you.
Thank you. Councilmember Rainville.
Thank you, Mr. Chair. Real quick question. In one of your slides, you talked about the action teams that you developed to send out, but I want to make it clear, we really couldn't request that as a city. Your action teams are done through counties?
Mr. Chair, Councilmember Rainville, so the action teams are primarily internal facing. So these are all state government folks right now. So, for example, the Justice Involved Action Team consists of my office, the Department of Human Services, the Department of Corrections, the Department of Health, the Department of Public Safety. And so what those action teams do is a lot of looking at what are the current suite of programs that we have in the state across those different agencies, and how do they all work together, and then start looking at identifying gaps. And then always we're in partnership and in conversation with our county partners, but they're not part of those action teams per se.
Okay, so you give long answers. How can you help us directly? How can you help the city of Minneapolis with its homeless problem, its addiction problem?
Mr. Chair, Councilmember Rainville, I think our role in this is primarily as a funder, and so I think as dollars are going out the door in some of those areas that we talked about, including some of the homeless prevention hubs, the low threshold access for medicine for opioid use disorder, there's other funding too that I did not mention that are coming through some different channels. I think making sure that our city partners and our county partners are aware of those funding opportunities, and helping align some of those so you can get the resources you need to address those issues. And then being a partner as well.
Thank you very much. Thank you.
Thank you. And thank you so much for being here. I think on the first few slides, it was about some statistics. I think it said 1 in 5 individuals were released from a correctional facility within a year and experienced an overdose death, and then the 1 out of 10 for people experiencing homelessness. Big numbers, I think, very much well seen here in our city, in Minneapolis. some of the programs that you talked about, are they geared towards these populations, and maybe some future coming programs that the state is looking at that could help, reduce these numbers would be helpful? If you could talk a little bit about that.
Yeah, absolutely. Thank you, Mr. Chair. Starting with the justice involved group, I think the proposal I mentioned at the end, that Medicaid 1115 reentry waiver, is probably the most powerful tool that we're proposing right now. Also, though, in the last legislative session, there was funding set aside for individuals exiting a correctional facility for presumptive eligibility for housing, so allowing individuals to secure housing as they're exiting. Many individuals are exiting from a Minnesota correctional facility into homelessness, and so that was an attempt to address that. There was also funding created last session, additional funding for grants that it's a federal program, but it was $10 million annually ongoing that helps fund for supportive housing. So there was some funding there, and then in the housing space, of which I can send you some follow up, but there was a significant amount of housing dollars that were passed in the last legislative session for the housing for homelessness.
Yeah, if you can send that, that'll be very helpful, and I'll just make sure to send it to our colleagues up here. And thank you so much. Looking at the overdose deaths, I think it said fentanyl was one of the major causes of that. I think 92%. Have you seen, at least from the state's perspective, have you seen the fentanyl testing kits, strips, as an effective model? And do you have any advice for municipalities, for counties, on ways to, advertise that better, help spread these across our neighborhoods? We know that if we can reduce that number, that would be very helpful, but I would love to hear your perspective on that.
Yeah, thank you, Mr. Chair. Absolutely. I think when we think of harm reduction, like we think of naloxone, we think of xylazine test strips, we think of fentanyl test strips. There are even more precise drug testing machines. They're called FTIR machines. I can't tell you the acronym right now, but they're very precise. And so I think part of the goal with those approaches is so people know what is in the substance they have. One of the biggest most alarming, I think, scary things about the current crisis is that oftentimes people don't know what is in the drugs that they purchase. They think they're purchasing cocaine. They think they're purchasing methamphetamine. It's actually got significant amounts of fentanyl, and so they dose as if it's pure cocaine or whatever, and it kills them. And so really helping individuals know what is in the substance they have is gonna help reduce deaths. I think we share a philosophical approach with the city and with the county in terms of wanting to get more of those materials out into the hands of people who need them. And so, we're looking to be a partner any way that we can in that.
Yeah, thank you. In Ward 9, there are a variety of transit hubs where we're struggling with this crisis right now, particularly by the light rail station. Councilmember Rainbow probably knows what I'm talking about, with a lot of overdoses there. Do you know, I'm trying to have some initial conversations at the city level too, but do you know any conversations at the state level happening with Metro Transit about the possibility of expanding these Narcan stations or something similar at these transit hubs? For example, you'll see a lot of overdoses on the Lake and Hiawatha light rail station, and they could result in deaths, and some of these, Narcan stations could help save lives of people that are, that are in crisis. So I'm just trying to figure out if you know any conversations at the state level happening with maybe Metro Transit, or any advice you would have on what we could do to improve overdose deaths in transit hubs.
Mr. Chair, thank you. So I can't speak specifically to that that specific conversation. I can say that that Metro Transit is part of the Unsheltered Action Team, and so we had a meeting just a couple weeks ago with the different state agencies, where each of the state agencies was sort of sharing what they're doing in this space. So talking about certain service programs, talking about some of the Metro Transit has the Transit Intervention Project, and so really looking at how we can respond as a system, how these interrelated systems can respond more collectively. And so while I don't know of any specific conversation about that, I think it's in line with sort of where the state is going.
Cool, thank you. I'm not sure if our city's involved with these action teams, but if they're not, I think given that Minneapolis is one of the highest places where overdoses, it might be helpful to have some city involvement there. And then the last question I had, I would love to hear your perspective on safe consumption sites, its effectiveness, and I know we're not there yet. I've been following the news, but would love to see like what pathway you see moving forward, what you're able to share, and then what it could look like in a place like Minneapolis.
Thank you, Mr. Chair. Yeah, I think we moved forward with this proposal last year, as I said, as a means of really opening up the toolbox to address the overdose deaths. Everything part of that legislation incorporated evaluation. We really want to know what the performance is. Like, how are these evidence based? Are these actually doing what we think and want them to do? I have visited Turning Point On Point in New York City. They have two sites, one in East Harlem, one in Washington Heights. They have some good data there that shows good outcomes. There was just Rhode Island just approved. They have their first state-funded opioid safe consumption site that hasn't opened yet, so we're trying to learn from them what they're doing. I think my perspective on this is I want to move carefully, and I think whether these are successful or not, I think is often going to depend on, and this is something we learned at On Point, is there sufficient education for the community, for people to know what these are, to know what these aren't, and for there to be enough community involvement so that there's good conversation between them. I know, for example, in On Point, they have a really robust community engagement piece, as well as intergovernmental relations in terms of conversations with the police department, conversations with the mayor's office, and some of those pieces. And so it's really so we want these to be successful, and so we want to move deliberately and carefully to make sure that they can be.
Yeah, I mean, that totally makes sense, and really cool to hear that you've been traveling where these already exist to see if it's ever implemented in Minnesota, how it could work. So thank you so much. That was my last question. Looking at the queue, I don't see anybody else. Jeremy, I just want to thank you for being here today, for coming to present to committee. Hopeful that this is us working together more in the future. I really appreciate the work that you're doing and the work that you brought to this committee. Yeah.
Great. Thank you, Mr. Chair.
Thank you. Seeing no further questions, I will direct the clerk to receive and file that report. The next item is receiving and filing a presentation in response to a legislative directive on the city's response to the opioid epidemic. Here to present on this item is Heidi Ritchie, Deputy Commissioner of the Health Department. Thank you so much for being here, Heidi.
Thank you. Give me 1 second.
Yeah.
I'll pull this up. Doesn't want to come up for me. Give me 1 sec. Good afternoon, council members. As mentioned, my name is Heidi Ritchie. I'm Deputy Commissioner of Health, and our opioid response team is part of my division. Also here with me, we have our program manager, Suzanne Young, and one of our opioid response team members, Tony Zaccardi. Also, Commissioner Chaplin is in the audience, and a couple of our partners, Daziwe Nataba. You may have remember him. He came and presented in front of council, Dr. D. So this presentation is in response to an opioid legislative directive, 2024-00158. There were two parts to that directive, and this presentation is on part one. So that is a needs assessment of staff, funding, and other resources needed to fully implement a comprehensive opioid response program. So any current or future state or federal funding opportunities, a summary of funding opportunities city will apply for, including application timeline and lead department, summary of additional staff and contractual dollars that would be needed to maximize successful applications, and any unmet one-time or ongoing funding needed. The second part of the legislative directive, which we plan on coming forward later this fall, has to do with overview of long-term strategies, a comprehensive overview of the proposed opioid response led by the health department, some best practices, and ongoing emergency programs related to social determinants of health that have impact on opioid response. So we'll be coming back with that, which will also include some budgetary needs that we won't cover here because we're in the middle of that strategic planning process. I just wanted to start really quick with a grant process overview. And so when we get a notice of funding opportunity or we're made aware of a grant opportunity, we do some initial vetting. We look at how much it is, what kind of assistance they're giving us, whether or not it's actual funds or technical assistance, things like that. And we really try and understand whether or not this would be a good return on investment for the city. Once we make that determination, oftentimes we'll go to a webinar and just ask questions and see if this is a good fit for us. Once we do that, we have to get on the council calendar. Sometimes it's a little bit of a game trying to make sure that we're able to get council authorization to submit the application. If you look on the right, those are eight criteria for when we have to come to council to get authorization to submit a proposal to the funder. After that, we have subject matter expertise meetings that culminates in a draft of the grant proposal. We submit it. It can take anywhere from a couple months to half a year to hear whether or not we were awarded. Then we come back to council for the council acceptance of the grant, and once that happens, then we enter into contract negotiations with the funder, and then we move to program implementation. So I just wanted to give a little bit of overview of that process. The upcoming slides that I am going to cover are really comprehensive around the opioid response funding. So we've got the 2022 and 2023 grant applications and awards, our 2024 grant applications thus far that we're working on, our opioid general fund budget, and then our opioid settlement and a couple different pieces of that. So in 2022, we went after 5 grants and were awarded 3. So the Space Cat for suicide, overdose, and ACEs, that was a $20,000 award. The SAMHSA Harm Reduction Program, that's a federal award. We were not successful in that grant. The COSAP, Comprehensive Opioid Stimulant and Substance Abuse Site-Based Program, we were awarded $1.3 million abouts for a 3-year period. We went out for the ORAC, or as Mr. Drucker said, that's the Opioid Epidemic Response Advisory Council. We did not receive that. And then the State Opioid Response, or SOAR funds, we were given $300,000 for a 2-year period between September 2022 and September 2024. In 2023, we submitted 3 applications to the county for settlement funds. One of them was in response to the state legislature's requirement around schools to carry naloxone. So we submitted a grant application to help prepare our schools for that, as well as help resource them. We looked at youth Narcan education and distribution, a youth anti-stigma campaign, and then hygiene services for encampment response and high services areas. We were not successful in getting any of those funds. We did get $25,000 from the state to work with us on the cross-section between human trafficking and substance use. So we're working with Sunu Shrestha from REIB in the city of Minneapolis to work on some of the community recommendations with that funding. In terms of 2024, we've identified so far 2 funding opportunities. One is for the Minnesota Department of Health Overdose Prevention Grant, and that's in collaboration with one of our community partners, Human. That's for a 4-year period. And then we've got one due this Friday. That's one that you saw on your agenda for working with our partners at St. Paul Ramsey Public Health to explore the efficacy, impacts, and feasibility of safe recovery sites. So that would be research, a lit review, potential site visits, engaging communities, and really doing a lot of the work that Mr. Drucker came up and talked about in terms of really understanding what safe recovery sites are, what they could be, what the continuum of services could be, and then what the data is out there, because we really don't know a lot. As was mentioned, there is a site in New York, and then there was a pilot in Rhode Island. There has been also a site in Philadelphia, but there's also that environmental and legal landscape that we really need to take a look at as well. So that is $400,000 for 2 years, so it's $400,000 in year one and another $400,000 in year two. For our general fund, the top few lines where it says BIS application or operating or telephone, those are just internal services. So that's about $11,000 of internal services. There's $400 of contractual services, and there's about $170,000 of salary and fringe. Now we'll move on to our opioid settlement funds. We received in 2022 a total of about $2.1 million. In 2023, a little over $500,000. And then in 2024, we just received a payment on March 15th for $200,000. We are expected to get another payment of around $500,000, but we know that these payments shift a lot in terms of their schedule, and so we really don't count on those funds until we see them in the bank. So here's our balance in spending. As of 2/29/2024, we had $2.2 million. I want to note that this also includes interest income. So the amount of spending, the amount in the bank, and the amount we received won't always necessarily match up, and that's because we've got that interest revenue that's coming in. Spent for 2023 has total been $276,287.45. 26 or about 27,000 of that has been salary and fringe, and then contractual services with Helix and Intersection Media. You might be familiar with the Helix contract. That one is for health and housing services, specifically around Ninocasi encampment. And Intersection Media was part of a educational awareness campaign we did with regards to Seve's Law, which is the Good Samaritan law we have in the state of Minnesota. For 2024 so far, we have spent $300,000, $10,861.52 have been salary fringe. Contractual services has been nearly $300,000. We have contracted with a number of community organizations, including Human, Helix, again, and then Generation Hope. And the Helix, that's just the continuation of the contact from 2023. I'll just, for the Human one, that's one that we contracted with them to help us with encampment. So they did health testing. They had a mobile unit where they had 4 RNs and 4 staff doing vaccines, handing out supplies such as take-home HIV tests, first aid kits, things like that, and doing vaccinations. Helix, I talked a little bit about them. And then Generation Hope, we just entered into a contract with them and a few other organizations for our Community Opioid Response and Engagement Fund. And thus far, they've spent about $10,000, I think, on that, or $7,000 on that. I went up. All right. These are the encumbrances. So this is the contracts we've entered into for things that we're waiting for, or for things that that the work is ongoing and they'll be invoicing us on a regular basis. So again, that's Helix Health and Housing Services, a mobile showering and restroom unit, our opioid response mobile unit rental, and that is kind of to tide us over until we get our own mobile unit. Our homeless encampment response, that $10,000, that was the contract with Human I mentioned just before this. And then our Community Opioid Response and Engagement Fund, or CORE Fund, We've got 362,458 remaining on that, and then youth education and prevention. I put actually both 2023 and 2024 settlement allocations that the mayor proposed and the council approved. In 2023, it was about 645,000. 150,000 of that was earmarked for underserved communities. In 2024, there was 672,856 ongoing and 680,000 in one time for 2.5 FTEs and a mobile medical unit, and then the ongoing expansion of First Step. There was also that $150,000 that was allocated in 2023 was intended to be ongoing. It just needed a little bit of a technical amendment in 2024 in order to fix that piece of it. So that is ongoing funding for the $150,000 for underserved communities. And then CPED was allocated $500,000 for Turning Point, which is a treatment center in North Minneapolis. As I mentioned earlier, we're going through a strategic planning process. Part of the money that was allocated out of that $645,000 in 2023 is going to pay for a contractor to help us put together a strategic plan. You can see here right now, going from March into April, we are in our strategy meetings. So we've met as a strategic planning group once, and we have another meeting coming up in April. Our consultants have been doing a lot of work to gather community input using focus groups, a community survey, our provider feedback, document collection and review, and then some informant interviews. This just shows a little bit of kind of the teams that we have working on the planning. So our core team is basically the consultants and then our opioid response team. And it also includes myself as the deputy commissioner and Commissioner Chaplin. Our subject matter experts are come to us by way of our consultant. And then our strategic planning committee is a number of people, both from the health department and then in internal departments. So as the lead strategist for opioid settlement funds, we hold that fund, but we are not the department that is 100% responsible for spending. As I mentioned before, CPED received $500,000 for Turning Point, and any one of these departments could receive funding. In the past, we know the fire department, we've worked with them on Narcan and Narcan vending. We've also worked with the police department in the past as well. And so you can see there's a good cross-section of departments that are part of the Strategic Planning Committee. These are some of our stakeholders. We wanted to make sure that we covered some of our different cultural communities, as well as some of the folks that we partner with, and then others that other jurisdictions like Hennepin County, the Park Board, to make sure that we're covering other jurisdictions as well. Here's another list of organizations and programs that we're attempting to engage through, and these are through a series of interviews and focus groups. You'll notice that there is a Native American partner provider focus groups, and that is backed up by the data that was shared earlier by the state, that there is a large disproportion between Native Americans and whites in terms of the ratio of overdose deaths. In the state, I can't remember what he said the state was, but in the city, for Native Americans, it's 30-1. So it's quite a bit of a bigger gap in the city than it is Hennepin County. Also in the city, we have about a quarter of the overdose deaths, whereas we're about 8% of the state's population. So our next steps is we'll continue that strategic planning process that I highlighted earlier. We plan to submit the joint Minneapolis Health Department, St. Paul Ramsey Public Health Grant application, and then we plan to report back to PHS with the information requested in number 2, no later than September 30th. We want to come forward earlier so that budget decisions can be informed by the strategic plan that we're coming forward with for the opioid spending. And with that, I will answer any questions.
Thank you for that presentation. Very helpful, Deputy Commissioner. I'll pass it on to Council President Payne.
Thank you, Chair Chavez. One just kind of broad question I have is around how we're embedding evaluation into a lot of these initiatives. We've gotten some feedback from things like, Helix operating at Camp Ninukasi. We were both there the day that the large encampment was evicted. It's a very chaotic environment, right? It's hard to keep track of things. We know as a city we're trying a lot of new ideas. Whether it's the violence interrupters, the behavioral crisis response, or especially in this emerging opioid response. And we're not always going to get it right every time. I'm wondering how we're just thinking structurally around how we're building in evaluation so that we can say, whether it's a month from now, a year from now, or 10 years from now, these were the interventions that were really successful. These ended up being great experiments. We learned something from them, but they didn't actually get us to the outcomes that we were hoping for, and we were able to adjust along the way. Do we have some structured ways of approaching that, or are we so early that we're not quite there yet? And then my follow-up question is, here at least on City Council, we've got a new oversight and evaluation department that, again, they're early in their development around what role they should be playing when it comes to ongoing programs versus new programs, what areas of focus should they be having? Is there an opportunity for some collaboration there? Maybe is a question.
Chair Chavez, Council President Payne, I think that's a really good question. We have a evaluation and research wing in the health department, and our epidemiologist, Luisa Pessoa Brandao, has been working very closely with the opioid team. In particular, when we do contracts like that with Helix, we do put metrics into the contract, and they have to report on those when they invoice us. We have received one quarterly report from them, and I believe I sent it out to council, but if you didn't get it, I would be more than happy to send it. But we always want to make sure we're refining those metrics to make sure that we're really getting at the outcomes that we want to get at. I would be open to collaborating with either PMI or oversight and evaluation, absolutely. And I think that the organizations we work with, they want to be beyond reproach, and so they are cooperative and willing to give us anything we need.
Thank you.
Thank you. I have just maybe two questions. If we can go back up to the slides about some of the applications we signed up for. I think the Hennepin County opioid settlement one. Right there, 2023. So I think we applied to, can you just talk a little bit more about the Hennepin County opioid settlement? Do you know much about who was awarded contracts or grants from them? Just curious, because it seems like we applied, didn't get any funding.
Chair Chavez, I don't, off the top of my head, have a list of all of the recipients of the Hennepin County grant. I can say that by and large, they funded community groups that already were getting funded by Hennepin County.
Perfect, thank you. Do you have a question? I'll pass it to Council President Payne.
Thank you, Chair Johnson. Chavez.
Johnson?
Yeah. So we know there's a deep intersectionality between opiate substance abuse and homelessness. Homelessness is a societal issue that we've lived with for a long time. Fentanyl feels like a very new societal burden. A lot of, I feel like, the conflict that does end up happen from a governance perspective is, what's the role of the city versus the county versus the state? I'm a very big believer that local government is the closest connected to the community and can therefore have a better understanding of what's happening on the ground and therefore be more responsive to what's happening on the ground. But I know that there's not always consensus on what the role the city should be playing, particularly in the area of homelessness. But in the area of the opioid epidemic, it's not, it doesn't feel to me, and we just had a presentation from the state. Councilmember Rainville asked specifically, what the role the state had. It was very much grounded in we are funders, and this does feel like an early enough problem that we have not really settled into the roles of the different forms of government. So first question is, do you see that as probably like a true kind of observation of the dynamic on the ground? And then my second question would be, do you see a very specific role for the city to play as we're thinking about how all layers of government can respond to these challenges?
Thank you for the question, Council President, and through the chair. I think that is always a challenge when you're working across government from jurisdiction to jurisdiction. We partner very closely with Hennepin County, in particular on the opioid settlement funding. We've had many conversations with them. Obviously, our consultant that's doing the strategic plan is connected with them. But we've had conversations where we are trying to make sure that whatever we're doing is supplemental and not duplicative. And I think that's where we're really looking at how we can support them. One of the things from the presentation from the state was looking at the incarcerated individuals and the challenges there are in keeping folks on treatment or when they get out, making sure that they have the medications they need. That's not something that the city does, but it's definitely something we can support them and help them with changes at the legislature that can make that easier for them. But we look at areas where we can partner with them that they aren't necessarily as strong in. So areas of prevention, especially around youth prevention, that's one area that we think that we can step into because the county is really focused on a couple other things than that. So yes, it can be challenging. That's why we have a really good partnership with the opioid folks over at the county. I think you're right in terms of us being, as a department, as local government, being more connected just by proximity to the community. And so we want to make sure that the resources that we do have are targeted to those most in need. And so that's kind of the approach that we take, is that the space that we enter into is making sure that with the limited resources we have, they're targeted where they're needed the most.
Thank you.
You're welcome.
Thank you. I have one more question, more about the strategic planning process. So is that process the focus area that's going to help decide where the funding is going towards, or can you just, I'm having a little hard time understanding that process.
Yeah, Chair Chavez, thank you for the question. They will be putting together recommendations.
Okay.
And so it'll be up to the council, once those recommendations come, the mayor and the council through the budget process, to really allocate that funding. This process is to help inform you on making those decisions.
Perfect. I'll probably reach out just for us to have a meeting about this. I think it's great. We'll have focus groups, the community survey, making sure that we can expand, get that information out to the community members that desperately need to fill these surveys out to show their perspective of what's going on. I can mention the Phillips area in general that encompasses Ward 6 and 9, has one of the highest overdoses, deaths, and encounters in the city. That data may have shifted since it's been last reported, but I'm pretty sure it's not. Want to make sure that folks in the area know how to give input and stuff. But that was the reason I asked that question. Thank you.
Chair Chavez, thank you so much. And Phillips area, central area is definitely still a hot spot.
Yeah.
Don't see that changing anytime soon. But I did want to thank council members for putting the survey in their newsletters.
Yeah.
I was pleased to see that go out. And as much community feedback as we can get, it's going to help us have a set of recommendations that is not only informative, but also it's credible.
Yeah. Thank you.
Thank you so much.
And thank you for being here. Really helpful information on a day where we had the state and the city do a presentation on this. So thank you. I don't see anybody else on queue. So seeing no further discussion, I will direct the clerk to receive and file that report. And seeing no business before us, I will declare this meeting adjourned.